So I'd like to go ahead and introduce our speaker today. His name is Russell Graham, and he is a registered respiratory therapist with over 30 years of experience in the respiratory profession and a previous Practitioner of the Year award recipient from the Texas Society of Respiratory Care. He is currently a Level 4 respiratory care practitioner at the Memorial Hermann Texas Medical Center in Houston, Texas. And Russell has both hospital staff and management positions during his career and served in leadership roles in various state respiratory societies, most recently as the president of the Texas Society for Respiratory Care. He has authored or presented several peer-reviewed works on various respiratory subjects, and most recently co-authored High-Velocity Nasal Insufflation in the Treatment of Respiratory Failure, a randomized controlled trial, which was e-published in the Annals of Emergency Medicine in January 2018. Russell is intimately familiar with HVNI, using in clinical practice for more than 10 years. And as a disclosure for Russell, this presentation is sponsored by Vapotherm, but important to note the participation by the speakers is not an endorsement of their hospital for use of any technology described in this presentation.
NIPPY is the first-line therapy for undifferentiated respiratory distress presenting in the ED. Remember, it's pressure-based therapy, and when we compare it to intubation, non-invasive has improved mortality, greater patient comfort than being on a ventilator, and it does reduce the cost of care, those are all good things. But we're all realists, and half of you are in this room are staff therapists, and we know that not everybody likes non-invasive. If you're claustrophobic, it gets worse. Nasal congestion, we always have to worry about skin breakdown, really have to worry about skin breakdown. We get frustrated as clinicians. We spend a lot of time trying to get the patient to do non-invasive, and then we put it on and they kind of wake up and take the mask off and throw it on the floor and say, I'm done with that. So compliance is a big issue. And because it is non-invasive ventilation, sometimes they just can't get in sync with the machine, which is a tragedy because the therapy fails for that. What do we do when they fail non-invasive? Well, traditionally, we've elevated their acuity. They end up on the ventilator, and because they end up on a ventilator, they're most likely going to the ICU. And interestingly enough, if you look at the Karen study, a third of non-invasive failures weren't attributed to the patient, their clinical condition. They were attributed to mask intolerance, and that's a pretty significant number for people unable to tolerate a mask.
But we want to know, in your hospital, what percent of your patients do you experience this mask intolerance with in your hospital? All right, thank everybody who participated. Let's share these results and see what we're seeing across the country. So Russell, it looks like the majority of the clinicians experience their patients being mask intolerant between 25 and 50% of the time.
Thanks, Nicole, and that would actually fall right in line with what they found in the study we previously mentioned, that about a third of people fail NIV. So if you know me, you know that sometimes I question conventional wisdom, or all the time I question conventional wisdom. And so you got to ask yourself, we've chosen to go down this path with this patient, but is there another option? And I believe there is. I think there is a viable alternative to non-invasive as we currently know it, because there is a wide compendium of patients that don't need to be ventilated but need something more than just simple oxygen. And we need a tool to manage signs and symptoms associated with respiratory distress, especially in the ED setting. We have a very short window of tolerance to get patients better. Anybody that's worked in an ED, I think, would agree with that. While we may not know they're hypercapnic, we need to fix that. We know they're hypoxic based on saturation. We know they're dyspneic based on presentation. And anybody who's ever had a patient prefer a cannula over or something less than non-invasive will agree that it provides more comfort. So high velocity nasal insufflation, at least as we saw it when we went into this study, presents a very viable alternative. And so a lot of this is the magic or mystery of how it works. And it does a couple of things. One is that high velocity sends humidified gas to the patient, fully humidified gas. But it does, and this has been studied and shown, it does a wonderful job of decreasing work of breathing by flushing dead space. That's not going to flush all the way down to the alveolus, but it will flush the upper airway of gas and provide humidified, oxygen-enriched gas for the patient's next breath. And it's called high velocity because there are a couple of laws that we might go back and look in our Egan's, as is referenced here, and find that if we have a volume of flow and we decrease a lumen, we increase the velocity. And so increasing the velocity increases the amount of flush without having to use all the flow. So it varies inversely with cross-sectional area of a tube. I think there's a guy we all studied that talked about that. But as your example, 5-liter volume of flow down a larger bore has a velocity of 16.4 centimeters per second on about a 5 cubic centimeter area. When that gets decreased, the velocity goes from 16 to 32 while maintaining the same flow because cross-sectional area cut in half. So velocity is distance divided by time. And that becomes kind of important in how we do that flush on these patients in any setting, but in this particular ED setting that we're going to talk about. So kind of a refresher, I think we all know this, but it's important to remember it. About 30% of your tidal volume is anatomic dead space. So essentially the first 1/3 of what you breathe in is the last 1/3 of what you breathed out. And at the start of inspiration, that anatomical dead space is filled with expiratory gas, higher in CO2 than in oxygen. And this volume and gas composition actually, in most cases, negatively impact your ventilatory efficiency. So let's move from talking about minute ventilation, minute volume, which is, I think, what we all think by, to alveolar ventilation. And it's really not a lot of difference to the equation. Minute volume is tidal volume times respiratory rate. And alveolar ventilation is tidal volume minus the dead space times the respiratory rate. And anytime you can reduce the dead space, you're going to increase the efficiency of ventilation. Or there was an animation going to show you that. The second piece of this is that the gas is humidified. There are lots of studies out there that talk about what we do with non-humidified gas, and we all learned all the way back in school, for some of us longer than for some of you who may be on the line, that optimally we want to give 44 milligrams of water per liter. When we don't, when it decreases, there are some negative effects as we move back across this graph. The first thing that happens is mucus starts to thicken because it has less water content. Then at a point, it becomes really adverse because the cilia quit moving, so you can't even clear the thick mucus. And then if it keeps drying out, you end up in this really harmful range that damages the cell because there isn't enough water being pulled back through the cell to help with that water content. So what is optimal humidification? Going to be the definition we'll use. Balance between avoiding condensation at lower flow rates, which is a problem, and providing sufficient humidity at higher flow rates. We may not always make 44 milligrams per liter, but we want to stay as close to it without causing the things we see. And anybody who's used straight aerosol therapy knows that condensation becomes a factor unto itself. but how it's delivered is as important as how it's created. So this is an animation of a vapor transfer cartridge in which the gas and the water diffuse through, the water diffuses through a membrane into the stream of gas going to the patient, and then that goes out down a tubing as humid gas, and then the excess humidity kind of comes back around. And it is delivered all the way to the patient. That's a cross-sectional cutaway for anybody who's ever seen the Vapotherm tubing. You know that it's a lumen inside a lumen. And your breathing gas runs down the center. Your return comes back out the outside. That helps maintain the temperature and the humidity in that gas getting all the way out to the patient. So the patient we talked about that we put on non-invasive is an actual patient. It was a patient of Sheldon Spivey's at Athens Regional Medical Center. Your results may vary, but we're going to talk about what was done for this patient instead, and how we think that this might help your clinical practice. We'll go back to those blood gases. Remember, your pH was 7.28, your CO2 was 74, your PaO2 was 78, you were 93% saturated, you were still tachycardic and tachypnic. And the patient's a 60-year-old with a history of COPD, arrived at the emergency department at Athens Regional. The initial assessment noted the tachypnea, nasal flaring, pursed lip breathing, bilateral wheezing, and a wet cough. Now, NIV was ordered but not initiated. The patient was started on high-velocity nasal insufflation at 25 liters a minute with an FiO2 of 60%. After the immediate application of high-velocity nasal insufflation in 44 minutes of time, the blood gas looked like this on the next slide here. We're 7.28, 74, and 78 to 7.41, CO2 of 53, and a PO2 of 68. Now, yes, the O2 dropped a little bit, but that was your 60%. But note I'm going to guess this is AM, not PM. Note your heart rate goes from 124 down to 113. And more importantly, your respiratory rate goes from 36 down to 22. So in this case, in Athens, they avoided an ICU admission by using high-velocity nasal insufflation. And that brings